This is Curious Incident, a podcast for special needs families and your window into the world of special education. Parenting can be challenging, and we want to make it easier by providing you with the resources you need to best help your child. Let's delve deep into the world of special education with your host, Adam Dayan.
I'm pleased to welcome our next guest on the Curious Incident podcast, Lisa Abbrecht. I also want to note today, the day of our recording, is my firm's 16-year anniversary. So, very exciting milestone for us. I'm happy to be sharing this day with you, Lisa.
Congratulations.
Thank you so much. Lisa is a clinical psychologist and has her own private practice called Orleans Anxiety and OCD, LLC. She works with individuals who are struggling to cope with uncertainty, helping them to understand how they can respond more productively to fears of the unknown. She has a passion for OCD and anxiety work, as well as learning about the underlying theories and implementation of therapy for OCD, including exposure therapy with response prevention, also known as ERP, and components of acceptance and commitment therapy, also known as ACT, which we'll talk more about. Lisa worked in health psychology at the Tulane Cancer Center and continued seeing individuals with OCD at the Behavioral Health Clinic. She continues to work as an adjunct professor in the psychiatry department at Tulane, providing the OCD didactics for residents. Welcome, Lisa.
Thanks for having me.
It's great to have you here. You specialize exclusively in adults with OCD and anxiety disorders. What led you to focus your entire practice in this space?
So when I was in graduate school, every year we had to do clinical training. So we would do practicums, year-long practicums, and then we would see clients in our departmental clinic as well. And for every client we saw, we would be supervised. So we would meet with someone an hour a week. And I had the opportunity to join a specialty supervision group in exposure therapy. And so this was mainly for anxiety and OCD. And I continued in that group second year, third year, fourth year, so all the way till the end. And during this time, I asked my supervisor how to get more training in anxiety and OCD because there weren't a lot of year-long practicums offered in that area. And so he recommended going to different conferences, and one he had recommended was the Anxiety Disorder Association of America conference. It's now Anxiety and Depression Association of America. And so that conference had a big impact on me, and I remember two specific sessions, one being on indecision and anxiety, and one being on OCD with Jonathan Grayson, who I'll talk about later, and an exercise I learned there. And so during the conference, I remember the indecision session in terms of just kind of simple daily stuff we deal with. And this is more a first world problem example, but I remember him talking about someone planning a vacation and they were going through all these what if questions. Should I go to Rome? Should I go to Paris? What if it rains in Rome? Oh no, but what if it's nice here? Oh no, but what if it snows here? All that kind of stuff. And it just kind of resonated with me because it made me think of just even, although that's, obviously more of a privilege, but daily decisions that we deal with and the what if questions that come up. And it made me wonder, how people cope or be more intrigued about how people cope with uncertainty. And so I left this conference really.
Just to interject, do you associate the what if questions with anxiety or OCD or both?
At that time, well, now I definitely associate them with both, which I'll certainly talk about more and elaborate on. I would say both for sure. At that time, I remember that session really stood out to me on what if questions around generalized anxiety and decision making. And for sure, both now.
Okay.
So I left there really thinking, how can I specialize in this? And the way it works in psychology and graduate school and getting your degrees, after graduate school, you do a year-long internship where you match somewhere. And you obviously need a certain number of clinical hours, and you have a better chance of matching somewhere with more hours in that area. And so I didn't, aside from doing this group for a few years, didn't have any of those year-long hours in anxiety and OCD. So I had matched for my internship in health psychology, which I was very interested in. But I made sure to keep up my training in anxiety and OCD. As you had mentioned in the intro, I also worked in the behavioral health clinic in the psychiatry department, and that's where I was able to continue seeing people dealing with OCD and anxiety, and also continue doing a lot of that work also in the cancer center. And then as soon as I was able to open a private practice, I knew that that's what I wanted to specialize in.
Nice. How did your early work in health and oncology shape the way you understand anxiety today?
So there's definitely a lot of overlap between those areas, especially in terms of acceptance work. So this comes up in oncology whether someone's in all different stages. So whether someone's about to receive a diagnosis or just waiting to receive a diagnosis and did some testing, they're deciding on treatment, they're waiting to find out what treatment they need, or they're in treatment, or they're, for example, doing chemo and they don't know if it's going to work, how it's going to work, if adjustments will need to be made, or they're post-treatment and they're in remission, but then they're worried about fears of recurrence. And so definitely a lot of acceptance work comes up around, just anxiety-provoking thoughts about their future and, will this work or will this come back, for example. And then so with my current work in anxiety and OCD, I definitely approach it similarly in terms of health anxiety, and working in oncology and health psychology is really, I'd say mostly although there was some adjustment to illness work, of course, and supporting families, there's definitely, most of the work is focused on health anxiety and coping with uncertainties, predominantly what I saw when I was in that setting. And so, and then as well as other medical settings I had worked in, just that fear of the unknown. And then also what if questions would come up a lot. So what if I never get better? What if this recurs? So that you can see a theme there that cuts across generalized anxiety, health anxiety, OCD as well, all those what if questions that come up. And then also a lot of what I'll talk about in terms of safety behaviors. So for example, with breast cancer, someone might be worried about a fear of recurrence. So say they're obviously in remission, they're worried it'll come back, and they start to physically check themselves, but then they're checking themselves daily. And so at that point, there's this anxiety sensitivity where they can't really, they may actually feel more symptoms or sensations than they would otherwise if they were checking less frequently. And then at this point, they can't really tell if it's going to come up. And then they also get wrapped up in checking or reassurance seeking. And so we talk a lot about not knowing if your cancer will return. How do you want to spend, like, let's say it were to return in 10 years or 20 years, do you want to have spent those 10, 20 years wrapped up in checking and worrying that the cancer will return? And so this applies to my work now, where we talk a lot about quality of life and how you want to spend your time.
I see a lot of parallels in what you're saying between health psychology and anxiety/OCD. And it's interesting because in the health scenario, there's rationality to the fear in the sense that the person is or has been ill. And so they've experienced something really traumatic health-wise. And so there's that fear that it could come back. Whereas in my experience, both professionally and personally with OCD, there's a lot of irrational fear. And we'll talk more about this, but a person is finding themselves afraid of things that have no basis in reality. So that is one interesting distinction, I think. And the other thought I had, I'll pause. I mean, was there anything that you wanted to say?
No, definitely. I was just thinking that it brings up for me the idea of, like, one might be more low probability. So, with OCD or some of the intrusive thoughts, there might be, it's not even necessarily that it's irrational, it's just, it might be a low probability chance of that happening. So someone might think, oh, I just had an image of harming someone, or I had a thought, and if I don't do X, Y, or Z, it's going to cause my fear to happen. And, that's something we obviously can't prove or we don't know, but we're not. So on one hand, we're not saying, oh, that will never happen. That will definitely never happen, or I'll definitely never do that. But we can definitely say, or most likely say, it's a low probability chance. Whereas with cancer, you might have, more statistics and whatnot to actually back up the chance that your cancer could recur.
Right, or maybe the irrationality is in the compulsions, the behaviors that some people come up with to address the underlying fear.
Right, exactly.
Okay. And the other thing I was thinking, more to just flag it, because I want to come back to it, what you said about, down the road, if the thing that you're worried about comes to fruition or if it doesn't, do you want to look back and see that you spent all that time worrying about it, which affects your quality of life? And I think to have that as a goal of, no, I don't want to spend that time worrying. I just want to have good quality of life. And if it happens, it happens. And if it doesn't, it doesn't. That's a great goal. I want to discuss, how does a person accomplish that, right? So it's a good idea to have in mind, but how do you actually go about executing that so you're worrying less and having a better quality of life?
And I definitely plan to elaborate on that, so I can now if you want. But when I talk about acceptance work, I'm definitely going to talk more about how we get there and how you get to that point where I really just factor in the quality of life piece and value. So a quick summary would be or give you a little preview would be, in terms of quality of life, so what we want to talk about first is the behaviors that someone is engaging in to try to cope with their worries and fears, so the fear that the cancer will return. How is that negatively impacting them? So how is this affecting their time with their family? Are they not feeling present in their daily life, whether that be family, work, just things that are important to them or people they want to spend time with because they're just so wrapped up in the anxiety. And so that's really like, what is the long-term effect of the way they deal with the worry? So there's the short term. So just some quick anxiety education, and I use the term safety behaviors before, is someone worries about something like their cancer coming back, and then they do something, they engage in some behavior to try to deal with that worry. So those are those safety behaviors like checking, reassurance seeking, going on Google, and that could be self-reassurance too, like, oh no, here's why it's unlikely, or here's why it might happen. And then over time, in the short term, those behaviors might bring some relief to the person. So they check and they feel maybe a little better. But those behaviors in the long run are keeping them wrapped up in the anxiety. So we really want to highlight how those behaviors are negatively impacting them, and that they can see that this is affecting their quality of life. And then those become their reasons to even change those behaviors, so that we can really highlight those values and what's important to them. And then once they start to change those behaviors and they go through exposure and do change those checking and reassurance seeking safety behaviors, they can get to a place where the anxiety is not eliminated. I mean, they're probably always going to have those fears of recurrence. They learn that, it's almost not realistic to not have those fears, and they learn over time that, they can function and they can be happy and present in their life, even with the fears of uncertainty. They just don't feel so wrapped up in them.
That's a great summary. Thank you. Many of the people you work with come in with a blend of health anxiety, social anxiety, generalized anxiety, and OCD. How do you help someone begin untangling those threads so treatment can move forward?
Yeah, so first, when people contact me, well, a lot of the times it's usually via email. And so what often happens is someone will say, hi, I'm looking for treatment for OCD or for social anxiety or health anxiety. And then whether via email or via phone, as we'll generally do a phone screen if I have availability, that's the next step, is I'll say, I need to hear more about what you mean when you say OCD, and what does that look like for you, or what does social anxiety look like? So basically, first I want to get a really good understanding of all the different anxiety that they're experiencing. And so part of that can be done in a phone screen, but then and the phone screen is to determine fit as well to some extent. And then obviously we can better determine that in person. And then once we start meeting, we really go through all the different areas of anxiety, including OCD, that they're experiencing. And I will say people are, I don't necessarily rely on this, but pretty good about bringing up different areas of anxiety. And so they might contact me for OCD, and then pretty quickly, for example, in the first session, they'll bring up, oh, I also deal with social anxiety. I worry that I'm offending people, or I send text to apologize to people, or I review situations. So this does come up naturally, but I certainly make a point to go through any different area of anxiety. And then
social anxiety is fascinating to me.
Yeah, I would say most people I see end up bringing up some aspect of social anxiety, and I really feel like a lot of people deal with that.
Do you want to go a little deeper with it? Talk about how it can affect a person day to day?
The social anxiety?
Yeah.
I mean, I would say especially nowadays, because I hear this a lot, I mentioned text messages. I mean, obviously conversations, but I will say people are constantly telling me they're worried they upset someone or someone's mad at them. And a lot of this is just even reading into the lack of emotion and tone that can come through text messages. So they're worried someone's upset with them or they offended them. And, and that person responding to them doesn't use exclamation marks or, just anything that would, or send an emoji or smiley face, that would really dictate to the person how they're feeling, and then the person on the receiving end takes that as a conclusion of their fears, basically. Mm-hmm. So, but it can come up in day-to-day conversation, and then reviewing someone's affect because you're trying to determine, are they upset with me? Did I offend them? Do they think I'm unintelligent? And then it can take it a step further where people often deal with that by apologizing to the person, or and then usually the friends will say, what are you talking about? So we take it a step further and say, well, how does that usually work for you? And so with social anxiety, and I know I'm moving into the treatment aspect, but we can talk more about it's not really functional basically the best thing is to learn to deal with the not knowing and the uncertainty, because it's not really functional on a day-to-day to constantly be apologizing to people or asking if they're upset with them, for that reassurance.
And when we were talking about acceptance work earlier, did you mean accepting the uncertainty, or were you referring to something different?
Definitely accepting the uncertainty. So in terms of social anxiety, when someone has a fear of offending someone or just worrying what the person thinks about them, or did I seem unapproachable to that person, the reality is, even if we ask someone, we can never really know what they're thinking. So we can't guarantee that their answer is the answer that we want or is the truth. And so not because people are lying, it's just we can't really know what someone's thinking. So it's definitely uncertainty based that you can't have that answer.
Sure.
And then also just in terms of you asked me how we link together basically the different disorders or sparse that out, is that basically the treatment is the same for all these different diagnoses. And I personally don't really, in the way I was trained, it's not as much about focusing on what diagnosis do they have, although I understand that can give some people comfort to know, I diagnosed with OCD or social anxiety. But I feel like people can often get stuck on those labels too. So for me, it's really more about what are they experiencing? So what behaviors, what types of worries are they having, and what behaviors are they engaging in to try to cope with the worries? But really the treatment is very similar for all of these different diagnoses, and they're all about uncertainty no matter which one it is. So just to give some examples, so in terms of health anxiety, so we could say something, all these what if questions that I referred to before can come up across all the different disorders. So let me go back. Generalized anxiety first is what if questions are really at the core of that. So what if this happens? What if this happens? What if this happens? And then they follow up with if then answers. Oh, if this happens, then this. If this happens, then this. And then you can see how someone can get really stuck in that. So they think that they're...
As a form of problem
solving.
For every potential scenario.
Yes. So they have trained themselves to think, or modeled off of someone, that this is helpful for me to try to prepare for every potential thing that I'm worried about. And in the short term, it feels like it's, okay, I have a solution to this, but really it's not helpful for them in the long run. And they're training themselves to do this all the time. And then in terms of health anxiety, someone might say something like, my arm is tingling. What if I have MS? I get a lot of fears about terminal illnesses, for example. And then some other examples, what if I don't check the front door and someone breaks in? It'll be all my fault. And just to highlight some different areas of OCD, what if because this is one that has come up a lot actually, what if especially in post-COVID world, what if I posted something inappropriate, like something racially inappropriate on the virtual chat during our meeting? And then and this could be just even, doesn't have to be work related, it could be on social media. I hear this all the time, that people constantly spend a lot of time going back in and checking the chat to make sure that they didn't post something that was inappropriate or offensive. And so that basically, you can see in all those different examples, some were OCD-based, some were health-based, some were social anxiety-based, that they're all about what if and this feared outcome, and then trying to doing something that they think will try to bring them some sort of certainty or give them an answer.
And so for a listener out there who's got anxiety or OCD and is hearing what you're saying and thinking, what do you mean? That's the responsible way to be. I think about what could possibly happen and I make a plan for dealing with it. Or I go over my communications and make sure I didn't offend someone, and they can't fathom a different approach or what someone who doesn't have anxiety or OCD would do in those types of situations. What would you say to that person?
I would definitely say I understand and I do empathize with people around that, and they're correct. That is a very rational and logical way to look at it, and that's really the way we're taught to look at things. I mean, you can look at advertising or books on anxiety, commercials. Nowadays, if people still watch commercials, it's, here's how to get control of your anxiety. Here's how to get rid of your anxiety, whether that's, mindfulness or medication. And it's not that that's wrong. And that, of course, our goal is, the reason we're doing therapy is to make someone cope better with their anxiety. But over time, they can see, at first through explanation of what is keeping them stuck and what's maintaining this anxiety, they can start to see that although those behaviors seem logical, in the long run, they're really keeping them wrapped up in the anxiety. And we'll go through various examples to help them get there so that they, until you really do the exposure and start to see it, you can't completely see, of course, the other side of treatment and how you won't feel like you're suffering with the anxiety as much. But we really talk a lot about, okay, this makes sense on the forefront that you're responding this way. But again, how is this really affecting you? So in terms of your family life, your work life, not feeling present, all of these things, all the time you spend trying to come up with answers. So even though those generalized anxiety responses seem and maybe are logical, on one hand, are they? Because we can't really know. So I really like to emphasize the uncertainty piece, because I think that's really something people get stuck on and don't realize is there's this illusion of certainty that is not realistic to plan for every scenario.
Right, and I think the time aspect is a good point. If you've spent an hour planning for 10 possible doom scenarios and none of those, I don't know where I'm going with this exactly, but if it's taking up a lot of your day, that's time you've lost that you can't devote to other areas of your life, spending time with loved ones or doing fun activities or connecting with people.
Definitely. And for example, I have a lot of people I've worked with who are worried that they're going to make a mistake at work. And so, or they're in a job where they're a physician and they're responsible literally for someone's life or death situations, and they'll spend hours checking and doing their notes. And I mean, they verbalize this to me, how much time it takes away from family life, or they can't stop thinking about it when they go home. Or even a more seemingly benign example, but not benign to the person dealing with it, obviously, is the generalized anxiety where I can't fall asleep because I'm just going over and over a to-do list in my head. And we talk about, we don't need to ignore it, but it might not really be functional at midnight to figure all this out. So you can commit to, okay, tomorrow at such and such a time, I'm going to sit down and come up with a plan on how I'm going to figure this out.
Mm-hmm. So we touched on this a little bit. We talked about the rational way that people with anxiety go about managing their anxiety and the way they get stuck. So why do those mental maneuvers actually keep people stuck?
So a lot of that comes from the fact that people with OCD and anxiety tend to be very intelligent people. I mean, you talked about rationalizing and using logic. So that's one thing where they really work. That's where those what if questions come from, and all these different scenarios, and then the if then responses. And I should add to that people with anxiety and OCD are also, especially I'll say with OCD, very imaginative, creative people coming up with these, elaborate scenarios. So they'll have a really bothersome thought, and then this whole scenario and, distressing scenario will come up, and sometimes to the point where it even feels real. Like, because I had this thought, it must mean something. And, that can be gory details. It depends on what the scenario is. And so with every scenario, they then are trying to do something to prevent what they fear from happening. So there's a lot of prediction and control going on. And so I can give, and obviously this keeps them stuck. And then I'll give an example. So with social anxiety, someone might, as I talked about, worry that they're offending someone, and it's really an illusion that they're getting that answer. So when they start to engage in those behaviors I talked about to try to get answers, they are really, to your question before, is they're getting stuck in thinking through it and the logic piece of it. So, or generalized anxiety, like it's a very intelligent thing to think through all these scenarios and be very logic-based and rationalize, but it's not working for them. And they can get stuck in it. So they get stuck in those behaviors. And then in terms of creative and imaginative, so there might be someone who's worried about harming someone else. So they're just going about their day and they have an image pop into their mind of stabbing someone. And then they're like, oh, why would I, especially the first time, obviously, why on earth would that pop into my mind? Wait, I have no desire to do that. No, I don't think I do. Like, why would I have that thought? And they then equate it to, does this mean something about my character that I had this thought? So there's that imaginative, creative piece where the mind goes with it, and then it's, why did I have that thought? Like, think of, we all have dreams, and we all have those dreams where we wake up and we're like, how did those people get together in my dream, or like fit together in my dream? Where would that have come from? And some people just think, oh, well, that was weird. Okay. And then they go on about their day. And then some people can actually really get very stuck on the dream or nightmare, if you want to call it. And they feel like they can't stop focusing on it. So it's kind of the same with intrusive thoughts, basically. And so with all of these different thoughts, it's really, people are engaging in these rationalizing, intellectual behaviors, because it is an intellectual thing to think, if I engage in this safety behavior, I can either get rid of the thought, I can potentially get an answer to if this is going to happen or not. And it's really, again, that illusion of certainty, or they think there's something I can do to prevent this from occurring. So if I look something up online, I might find out if I have this illness or not, and then I might be on top of my care, which really is a very rational way to look at it, and sometimes that does apply. So when I work with people with health anxiety, we talk about not ignoring symptoms, but coming up with maybe a plan. So, okay, if I still feel this way in X amount of days, or this gets worse, then I feel that that's reasonable for me to contact a physician, but not necessarily going off of what they read online or having, stepping away from their reaction for a second, or their reaction to look something up.
Mm-hmm. That makes sense. Okay, so let's talk about treatment. For listeners who may be new to OCD treatment, can you explain ERP, exposure and response prevention, and acceptance work, which we've talked a little bit about, and how the two work together in treating OCD and anxiety?
Definitely. So ERP is really based in, it's a behavioral therapy. It's really based in, which I won't go into detail, make it more concise, but it's based in what we call learning theory. And so basically what this involves is understanding someone's history and in context. So in the context of the environment and how behaviors get maintained. It involves conditioning, and so how people, conditioning and reinforcement. So how people respond to certain triggers and stimuli. And over time, again, how that becomes maintained. So in terms of ERP and ACT, what I first like to do is I always give someone, I start treatment with anxiety education, and that's really talking about how behaviors get maintained. So I reference this, how just a quick review is in the short term, someone feels anxious about something and engages in a behavior to try to reduce their anxiety, whether that's get an answer, try to prevent, so they think it's preventing something from happening, and they realize, we talk about how in the long run, that's really not working for them for various reasons. So once that education's on board, and included in that education, we also talk about stuff like safety behavior. So a lot of those behaviors people engage in are reassurance seeking, and that could be with yourself, things you say to yourself, asking other people, looking online, checking. So that could be checking yourself for something, physically checking something like a door, mental, internal review. Avoidance and escape are big ones as well. If I remove myself from this situation, then, I have to get out of here. It's too crowded, that kind of thing. Or I'm not even going to go do that altogether, because then I won't even need to now I don't even need to deal with the anxiety. So, and then behind this is those, I'm sure you remember back in school, those fight or flight reactions that we've all learned about. So your body reacts to various triggers and stimuli as potential danger signals. So these behaviors are adaptive for us. So we're taught fear certain things. So it's actually adaptive to fear a tiger or a lion. So you see the lion or tiger and you have this reaction to productively get out of there, right? Or a bear. And although some people say you're not supposed to run from bears, but nonetheless, you have this productive reaction and response to get yourself out of there, because that is actually dangerous. And then there's fears that we pay for. We pay to ride roller coasters, to watch horror films. We actually want to be afraid in these situations. But then there's the situations in terms of anxiety and OCD and intrusive thoughts where we have one. So I mentioned maybe that first time that person has that harm intrusive thought. What if I stab someone in my family? What if I stab my child? And obviously that is alarming to them. Now, someone might have that thought and think, oh, that was odd, and go about their day. Someone else might have that thought, and they then respond with danger, and they are reactive to it, and then they start to respond by avoiding knives or avoiding cooking, and this is something that they were doing before for their family. And so you can obviously see that effect over time, but basically what happens is the person is responding to the danger and these alarm bells go off. This is dangerous. I can't have this happen. And then that leads to this maintenance over time. And the person starts to listen to their thoughts on, I can prevent this. No, I can't have that happen. So the exposure involves slowly exposing yourself to what you fear. And the response prevention is key. So it's not just exposure therapy, but it's exposure therapy with response prevention for a reason. And what that means is when you're doing exposure therapy, it's imperative that you actually don't engage in those behaviors, those safety behaviors I mentioned, such as checking.
And the longer the safety behaviors have been going on, the harder the ERP exercise is going to be. If a person has been avoiding knives for 3 decades, it's going to be a lot of work for them to undo that, correct?
Oh, definitely, for sure. Especially if they're, I will also say the longer it's been going on, that's one side. I'll also say sometimes with people where it's a newer diagnosis or newer experience of OCD, it's not necessarily hard in the same way because they haven't developed all those behaviors yet, but they're not, for lack of a better term, used to having OCD. So there's this hump that they have to get over, I'll call it, where they need to get used to the fact that this is even happening to them. They're even having these bothersome thoughts altogether.
I've never heard it put that way before. Can you say a little more?
So I've obviously noticed this over time in working with people, and I'd say actually this happens a lot. And I can even think back in the last year, probably most people that I've been working with, where people come in and they developed OCD at a later age. So meaning they just haven't been experiencing it since childhood, or they were a teen, or so maybe they're in their 30s, for example. And, everything was going fine for them as they feel. And then they started developing these intrusive thoughts. So it could be about self-harm, so worried that they're going to harm themselves, worried that they're going to harm someone else. It could be dwelling on things that they've done. It could be, obviously a number of things. And obviously they're probably engaging in behaviors to try to, prevent those fears from happening, like those safety behaviors like we were talking about and you just asked about. But they're also stuck on the fact that they're even having these thoughts. So what will happen a lot is people will say, I was going about my day and I was having a great day or a great time with my family, and then the thoughts showed up. And they just can't get past the fact that these thoughts are showing up at all. And thinking, well, maybe there's something I can do in anxiety, OCD treatment that will get me back to a time where the thoughts aren't, basically before OCD started.
Which is inaccurate, right? The point of treatment is to help the individual tolerate those intrusive thoughts or anxieties.
Definitely. And it's also working towards acceptance of the fact that this is happening, is that this is part of your life now, that you are having these thoughts. We can't control what thoughts come into our mind. And as you said, it's unrealistic to go back to the time before these thoughts were showing up, and you'll continue to suffer with it if we look at it that way.
Mm-hmm.
With the exposure, we're not necessarily needing to do a hierarchy. I know that was talked a lot about back in the day. And really, I tend to not start with the most bothersome or most uncomfortable thing, but we want something that's going to be challenging enough. So basically confronting their fears, learning that they don't know, obviously, if this will happen, but also that they can tolerate it. So although we don't want to get stuck in every scenario like I talked about before, we also want to learn, okay, if this happens, I will deal with it. So, because a lot of the times people will have the feeling, well, I can't have that happen to me, or I won't be able to handle that. So in the case of a health diagnosis, medical diagnosis, for example, we'll talk about, okay, well, what if that did happen to you? So I know before I talked about not getting caught up in what if scenarios, but there are sometimes we'll talk about, okay, if you were diagnosed with cancer, what would you do? And I would ask more questions, or who would you have come with you? Who would your supports be? And talking through all this, we can talk about, okay, obviously I still don't want that to happen to me, but I can deal with it, and I will deal with it if it happens to me. And then in terms of, so ACT stands for Acceptance and Commitment Therapy. And ACT is a therapy that can obviously be done on its own, but I really use components of ACT to enhance the exposure work. And actually, when I was in graduate school, I did my dissertation specifically on using ACT to enhance exposure work for intolerance of uncertainty. So I've always been very interested in this. So I'll give a little summary. So one of the components of ACT is willingness. And we'll talk about this in terms of readiness for treatment too. But basically, someone needs to be fully committed to doing exposure work. So we talk a lot about, as I mentioned, how are these behaviors negatively impacting me and what's the cost to them? And why would I be willing to even do this exposure work? So why would I be willing to stand next to a knife in the kitchen near my child? Why would I be willing to not check the door and have the discomfort that comes with that? So that response prevention
sounds like that piece comes back to values.
Definitely. So that's my next thing is values. So we talk certainly about values in terms of what is important to someone. And so oftentimes people will say something like, well, my love for my family is my main value. And we talk about, well, okay, how are you involving your family in your rituals? Are you asking them constantly for reassurance? And so skip to the end is the answer is yes, the person is very much involving their family in their rituals, and also, or just the behaviors the person is engaging in are affecting their time with their family. And so I'll highlight that discrepancy. Like, well, you say you really value and love your family the most, but actually this is all really negatively impacting them, and that doesn't match. So we absolutely talk about that as a part of treatment and willingness and readiness to engage in treatment. And then also related is this present moment, present-centered mindfulness piece. So again, if you're...
Sorry, before we get into the mindfulness, I'm just wondering, can you put yourself in the shoes of the patient? What is that moment like for them where their values come in conflict? They think that they're prioritizing their family and hopefully through therapy realizing that the OCD or the anxiety or the safety behaviors are butting heads with positive quality time with family. And then, what is it like for them when they have that realization? Or do they have that realization?
I will say most people do. I really feel like we can't move on. They're not really ready for treatment unless they do. So some people will react somewhat defensively in terms of, what do you mean? Of course I love my family. As if, we're saying you don't love your family. But I will kind of harshly, although there's empathizing, harshly point that out in the sense of like, but this really isn't aligning. So if this is really, it's not about do you love your family or not necessarily, but it's about if this is really what's important to you, let's really look at the effects of your behavior. So then we'll go through these various examples so they can realize, oh, wow, this is really affecting them, that I'm calling them all the time, or I'm making them return back to the house so I can check something. Or I'm constantly asking them for reassurance, whether that's in person or via phone. And they really start to get a sense for how this is affecting, or maybe they'll ask their family members. Maybe they haven't even asked them before, and they'll be surprised by their answer of how it's affecting them as well. And I should note that oftentimes I end up giving family education as well about these accommodating behaviors. So family accommodation is a thing in OCD, whereas sometimes the family doesn't even realize that they're contributing to the problem as well.
Yeah, I think it's, I don't want to belabor it, but I just think it's really interesting, people having that compulsion of, I have to do these things. my family is the most important thing to me, but I have to do these things, and then they're my number one. And that moment when you realize, wait a second, all this stuff that I feel I have to do is getting in the way of what really matters to me.
Definitely. And something I was going to talk about with ACT is this language component that you just not made me think of as I was going to bring it up. But I was going to bring that up in the context of there's this feel, exactly what you said. So there's this getting stuck on the language and that getting reinforced. And what I mean by that is the person will have the thought, literally, I have to do this. I can't go to sleep until I won't be able to sleep unless I do this, or I can't leave the house until I do this. People say those have to, need to, can't wording to me all the time, and that terminology. And what I say, I really empathize with that is like, I believe you in that it truly feels that you have to do these things. And so I really, it's important to me not to dismiss that, but at the same time to highlight, I know it feels like you have to do that, but physically you actually don't have to. So it can feel like you have to, even though you don't physically have to. And people do usually have a good response to that. Like, I know you understand it feels like I have to, and like, okay, yes, I could move my arm unless I have, some disability or an injury and I actually can't do that. And I can do that, but at the same time, let me try to separate from that, have that be there, but separate from it to see how is this affecting my family too. I mean, we talk about this with depression, and the main treatment for depression is behavioral activation. So someone might say, I can't shower, I can't get out of bed. And so again, I empathize with I know it really feels that way, that you can't get out of bed. But the more you listen to those thoughts and don't get out of bed and don't make yourself shower or commit to doing that, the more that gets reinforced, that belief that I can't do that. So with exposure work, what's really important is committing. So this is where the willingness comes in and the understanding of language. We only do things in exposure that someone's committed to doing and not something that they're going to try to do. Because the problem is they'll try it and they'll say, no, that's too hard for me. And then they'll reinforce the belief that they can't do that. And then I just want to add, so with the language component of ACT is huge, and we'll call this diffusion, and the opposite is fusion. So people get very stuck on listening to their thoughts, as we just talked about, and then there's also the making meaning out of their thoughts. So they'll get stuck on, this means something, that I had that thought, and then they'll base their behavior and their responses off of that meaning.
Something about their character, you mean?
Yeah, so it could be, this means something about my character, that I had that thought. So there's this also thought-action fusion in OCD. So having the thought is basically, to them, just as bad as having acted on the thought. And so that then means something about their character. Or it could just be they're reading into the distressing thoughts they're having, and then oh, I can't have that happen. And then they're then engaging in those behaviors that keep them stuck because they think they're preventing something from happening. Mm-hmm. I will just add that, just to wrap that up, is that the way that the way I use ACT to enhance exposure work is the willingness component of ACT that we talked about. So willingness to engage in the exposure and commit to it and take the risk, because these are risks. Like, I might get sick from doing that. We're not saying that you won't. It's just about quality of life and why would I do that? So coming back to those values and why would I engage in this exposure behavior, and then also learning to be more in the moment. So feeling able to enjoy what you're doing. So I can be with my family and be present even if the thoughts show up. And so you can see the effects of that over time. And then also the language component of getting unstuck from your thoughts, noticing when you're making meaning out of your thoughts, and listening to your thoughts. So those all work together to enhance the exposure work.
Yeah, I think challenging that idea of I can't enjoy the time with the people I'm with if these thoughts are interfering. It's too distracting. It taints the experience. Pushing back against that and reminding yourself that both can be true. The thoughts can be there, and you can enjoy the time with the people you're with.
Definitely. And people often say stuff to me, oh, I went to a basketball game last night and I was really looking forward to it, and I just couldn't stop thinking about what happened at work or what I might have done or mistakes I might have made. So we want to learn, how can I have these thoughts and have them as background noise, basically, because it's not realistic to not have them, and we don't know when they're going to show up and if they're going to show up. So let's make it so that we can have bothersome thoughts show up, because they will, but also focus on what we're doing.
So we've emphasized that an individual needs to be ready before starting ERP or ACT work. What does it look like when someone is ready for treatment, particularly when their compulsions are internal and may not be apparent to an outside observer?
Really, I'll tailor my examples to internal compulsions. But so first I want to say, I'll mention, I know we were going to talk a bit about the conference, but I've been fortunate to be unofficially mentored by Jonathan Grayson, who I
love. Jonathan Grayson.
He's the best.
He was a highlight of that conference.
Absolutely. I will say he got me hooked as well early on. And I look forward to that every year, I would say, especially because of him. So I call him the uncertainty guru. I don't know if he knows that, but I do call him that. And he has these exposure and response prevention ERP motivator sheets. And I already talked a little about these in terms of you need to be ready for treatment, as we discussed. So what he does is he has talking points, and these are categories of the way that you handle your worries, OCD or anxiety. How are these negatively impacting you? And basically, what are the costs to your behavior? So we need to go through these so the person is really clear that there's a negative impact on them and they have strong reasons to want to change these behaviors and do exposure. So some examples of the categories he uses are lost and wasted time. So, obviously internal compulsions could be being stuck in your thoughts, trying to figure something out in your mind. You can obviously get really stuck in that and say, oh, wow, an hour just went by and I didn't even realize. And then it's affecting their work, their family life, all of that. Or we talked about being at the basketball game or being with your family and you're stuck in your thoughts and compulsions. This might be a little bit more outward, but being embarrassed or humiliated about behaviors that you're engaging in, or constantly asking people to return home because you forgot to check something, or calling them at the house, or that kind of thing. Also, losing out on things, missing out on things, being late for things because you're stuck in your thoughts again, or the next day, or you didn't sleep because you're reviewing something in terms of social anxiety. Again, did I offend the person? Also,
what's a telltale sign that a person is stuck in thought as opposed to just thinking?
So I determine that by ask a lot of questions about, okay, what was the worry? Okay, then what thought did you have? And then what? And I really can training the person in a sense to be attentive to this. So I can then tell and look for any subtle reassurance seeking behaviors. So, oh, wait, they're actually trying to figure something out. They're trying to get an answer for if someone is mad at them or if they offended someone. And this isn't just, a functional problem. We try to, I look for the difference between worrying versus problem solving. And a lot of people think that when they're worrying, that they're just functionally problem solving.
Well said.
So another aspect would also be relationship effects. And he has a whole sheet that is just geared towards the effects on your relationship, such as involving someone in your rituals. And that can be a partner, friends, family, really any kind of relationship. And so in terms of internal compulsions, it could also just be the effect that this has on your relationship of just not feeling present. So you can see how all these different categories, in a sense, relate to each other. And so even I mentioned some examples before of like suicidal OCD. You're worried you're going to harm yourself. Someone could easily get stuck in, well, no, I don't want to do that. Why would I have that thought? But does that mean something about me that I had that thought? And they're just, obviously very distressed by this and stuck in it, and then they can't feel present in their relationship. And then will also say with that aspect of OCD, there's a lot of, not necessarily embarrassment, but worry of telling other people, whether that be your partner or even your psychologist, your therapist, because you're worried that they'll, commit you, or they're going to have to report me or call 911 or that kind of thing as well. So, but point being, with all these different categories is you go through them and you can really see how it's negatively impacting you. And this usually makes someone ready to engage in and willing to engage in exposure work. And that really has to be on board.
What do you say to those people who are feeling shame or fear that they'll be committed if they share this with someone?
So I'm glad you asked that, and I think it's important to say at first, I do always give someone education that this is OCD. So, and I won't keep giving that down the road and they know this too, that this is reassurance. So people will often, the reason I'm kind of laughing is people will later down the road, in a sense, laugh because they know they're asking me for reassurance, and they'll say, okay, I know you can't answer that. But at first, most importantly, is I always give the education that this is OCD. So what OCD looks like, for example, in terms of suicidal OCD, is you have a fear, you have an image or thought about harming yourself, but that's very different from wanting to harm yourself or having the feeling that you don't want to be here anymore, or things would be better off if there's what's called passive suicidal ideation is, and this would come up in oncology, is, you know what, this would be so much easier if I wasn't here anymore, which is passive because they're not necessarily wanting to harm themselves. But what's very different in OCD is the person has a worry or fear that they will harm themselves without any desire to actually do so. And it's so bothersome to them that would even cross their mind. Mm-hmm. I talk a lot about this in training. I learned a lot about this in training, and then with psychiatry residents that I work with when I do the OCD lectures, I really like to educate them because we talk a lot about, I'll have patients who have come in and say, someone referred me to a psychiatrist, or I was meeting with a psychiatrist and I told them about these harm intrusive thoughts or self-harm intrusive thoughts, and they were really worried. They were actually worried that they wanted to commit suicide. So it's really important to me that providers are trained in knowing the difference between that and OCD so someone gets the proper treatment.
Absolutely. I know we've talked about the idea of an OCD demon. We've also discussed sabotage in the context of OCD. And so I'm wondering if you can say a little bit about those ideas and also about the internal dialogue that's always happening within somebody who has OCD, or maybe needs to be happening in someone who's struggling with OCD.
Yeah, so definitely so I'll say a lot of exposure isn't necessarily physical, even though we might be when we're in the office or outside the office, because we want it to generalize to different contexts, can be physical. But even if you're doing an exposure that is more physical, meaning like doing, so physically not checking the door or purposely contaminating yourself, you're constantly dealing with, so even during that exposure, you're dealing with the fears you have. So, oh no, I'm definitely going to get sick from touching that. I'm definitely going to get sick from doing that. And so during the week when they're not, at their session, that's what their life looks like, is they're constantly dealing with these what if thoughts, even if the actual worry is something more seemingly physical in nature. And then you mentioned the OCD demon. So really what happens with people with OCD is the mind likes to sabotage. So they'll be maybe productively doing an exposure, and I really like to try to prepare people for this and let them know that this is what happens. They'll be doing this exposure, and then these sabotaging thoughts come up. Well, no, but I don't think you really checked the door. No, I committed to not checking the door. Okay. But someone might break in, and then it's definitely going to be your fault. no, I'm not going to, no, I committed to it. I'm not listening to that thought. And basically what happens is these sabotaging thoughts they're almost like arguments as to why the person should engage in some sort of safety behavior. And so I like to tell the person that these thoughts will come up and the mind likes to challenge them, and it's their job to recognize that and not listen to that. And something else in that context that I talk about a lot is the difference between discomfort, so the thoughts being uncomfortable, and the thoughts being a problem. So we talk about the fact that these thoughts are going to come up and it will be uncomfortable, but that's not a problem, because people will often say to me, almost as an argument for like why they feel they had to give in to the thought, is like, oh, but the problem is I started thinking about this. And so I highlight, again, you can't control your thoughts and they're going to come up. So it's not a problem, but it's uncomfortable.
Yeah, that's good. So for those people who are feeling angry or frustrated about the thoughts that they're having, how do you help clients move toward acceptance of uncertainty and tolerating distressing thoughts? And talk about fantasy versus reality in this context.
Yeah, so I'll often notice that, so as we talked about, people definitely get stuck on the fact that these thoughts are occurring, and it can be a major roadblock in therapy that we really need to work towards that acceptance before we can, in a sense, move on with therapy. And so early on, I'll talk a lot about, and actually Jonathan Grayson uses this term, as the wishing ritual. So basically someone gets stuck on wishing this wasn't happening. So they'll say things like, if only this wasn't happening. Or I tell them, if your thought has the ring to it of, if only this wasn't happening. And again, we don't get that luxury. So we talk about how there's a difference between wishing or being a little frustrated or bothered at first that the thoughts there are uncomfortable versus dwelling on it. And then we talk about, as you brought up, the fantasy versus reality is, so this will come up a lot with decisions that people made. So they'll, in a sense, berate themselves for the decision and say, if they don't have the outcome that they wanted, or they're worried about the way something turned out, it's like this hindsight, bias and fantasy world of, oh, if only I'd made this other decision that I was thinking of, things would have turned out okay. Or I should have known that. And they'll come up with this evidence as though they should have known something.
What's a person to do about that?
So really what I do is I basically point that out to them and give them certain, let's say, statements that they can say to themselves or observations. So let's say something to themselves like, oh, I'm wishing again, or, oh, there I go, telling myself that things definitely, I use that word for a reason, definitely would have been different. Oh, if I'd only known, as if I could have known. So I actually use those terms, wishing and fantasy.
Great.
This also made me think of, I don't know that you want to add this or somewhere, it doesn't exactly fit here, but it made me think of the fact that, I guess it's just noticing what our mind does is that, so when we were talking about language before and evidence, the word evidence comes to mind. What comes up for me is when people's minds come up with those, for example, sabotaging thoughts, what happens is we have a fear that maybe we did something. So like someone with pedophile OCD who's worried that they harmed a child and it feels real to them, their mind will then come up with evidence as to, oh, here's why that happened. So they might look and, again, scan the person's affect or look at their clothing, or do they seem upset? And their mind will tell them, well, here's evidence. So part of it, kind of actually related to what I just said, is they start to listen to those thoughts and say, they start to tell themselves in a functional way, this is what my mind does. Oh, there I go. My mind's coming up with evidence again. And that's what my mind does. So not to necessarily ignore it and say, oh, that doesn't mean anything because that's what my mind did. But to say, I have to be careful about latching onto that because this is what my mind does. And I don't actually know that that's true. That's not an answer for me.
Mm-hmm. That's a great illustration. Lisa, we met at the International OCD Foundation Annual Conference. Do you want to say a few words about the conference and how it can be a resource for those suffering from anxiety and OCD?
So I will start by saying this is by far my favorite conference. I attend sometimes 3 conferences a year, somewhat similar areas, so anxiety related or treatment that applies to anxiety and OCD. The reason this is my favorite conference is that I find it to be the most valuable. It's really the only conference that I know of, not even just the anxiety OCD world, but in psychology, in that psychology world where it's both providers and people with OCD that come to the conference. And I've found it extremely valuable because you can attend sessions related, just for therapists that are just for therapists. You can attend sessions that are for individuals with OCD, families, and I've really enjoyed the sessions for individuals with OCD in the sense that you'll often have these panels. So you might have a therapist who's obviously providing treatment, and then there might be people on the panel, obviously, who are individuals with OCD. And I remember one panel on relationship OCD that I found extremely helpful and to bring back to my patients to talk about and that's a really hard one for couples to go through, and to hear these couples who've gone through the treatment, and then especially what it was like for the partner of someone with relationship OCD and how treatment helped them as well. I found that just to be extremely helpful and meaningful. And then at the conference every year, as you know, I do the Road to Recovery tour with Jonathan Grayson. And what we do is it's a pretty large group, but we take the large group out. He does a little speech at first, and he uses a lot of his basically motivational components of why would you take these risks. And we go and we do exposures for different areas of OCD. And although sometimes people will tell me the next day I do a support group or a debrief about the tour, and people have told me at times, oh, my area of OCD wasn't highlighted in the tour, but they found it extremely supportive or helpful. Or we talk about the fact that although it's not always feasible to do smaller groups and touch on every area, that there's a supportive component in it for everyone or for other people who are dealing with that aspect of OCD.
Do you want to give some examples of the exposures that happen on the Road to Recovery tour and what the purpose or intended effect is?
So some examples we go through. So we go through examples for, and I can be more specific, but harm OCD, contamination, work, worrying that your thoughts are causal. There's a hoarding component. So for the harm component, he asks who struggles with harm OCD. And so he brings a bunch of knives, and we make 2 lines, and those people run through the lines with their knife. And I should say the 2 lines facing each other that are narrow, and, where it feels like there's some risk, and they run through the lines with their knives. And although there's some, I can say this humor aspect to it, in that even the people who struggle with this, although they do find it hard, some of them will have some humor about it, they still do report that they'll find that effective, or it somewhat touches on their daily experience. When we were talking a little bit about the crash and burn exercise. So for people that worry that their thoughts are causal, or if I don't do X, Y, and Z, or if I say this, it's going to make it come true, we'll say, who worries that their thoughts are causal? And so we do this exercise together where we stand at, if possible, a busier road, or at least a road where we know cars are going to come by. And we say, we all yell, and this could be like 200 people yelling, crash and burn, crash and burn, crash and burn. And so that's one example of those internal, let's say, compulsion or thought-based exercises that we do. And then we also do contamination. So we usually end it by going back into the hotel, and everyone does this, whether they struggle with it or not. Again, just as support, but where we go in and rub our hands on the toilet and grab a Tic Tac and eat the Tic Tac without washing our hands. And we talk about not washing our hands when we go back to our hotel room.
Yeah, it was a powerful experience.
For sure.
Thank you for giving those examples. Speaking of Jonathan Grayson, I know he's got that prompt about writing down that a loved one will die painfully. I'll let you describe it, but do you want to talk about why that exercise is effective and what it teaches about thought control and acceptance?
So at that first conference I went to that really got me hooked on anxiety and OCD work, this is where I went to a session and Jonathan Grayson did this exercise where he said, write down, and this is at the time where everyone was using paper and pens and not their phones, but write down the name of a loved one or someone you love very much. And then he'll pause and say, now write down, I'd like them to die, or they're going to die a horrible and painful death. And then obviously pauses. And the quick version is he'll start to point out, I saw you rip up your paper, or I saw you erase that. And people will quickly admit, I erased that. No way I was writing that down. And I do this with psychiatry residents now as well. And it's really to give someone who doesn't have OCD the experience of having OCD. So what happens is, so with the psychiatry residents, I've found it really impactful. And for instance, last year it stands out to me when I did it with them, they're writing it on their phones and they immediately said, oh, I erased that. Or there's no way I was writing that down. So this is what I was going to write down, and there's no way I was writing that down. And so we talk about the fact that people with OCD don't have that luxury. So it gives them that insight into how uncomfortable it would be. So imagine if you couldn't erase that, and that's what it's like for people with OCD, is they don't get the choice to not have the thoughts.
Mm-hmm. Wow. The OCD and anxiety community is known for being incredibly supportive. What role would you say support groups, shared stories, and community play in healing?
I would say they play a huge role. So first of all, people might relate just the fact that they know other people experience distressing thoughts is extremely comforting to them. And even if the thoughts are different themes of OCD, I always have people come back to me who've gone to support groups or the conference or watch live streams, tell me just how comforting that is to know they're not alone and other people. It feels like, anytime someone knows what it's like, or it seems like someone knows what it's like, it's really comforting. And so we just really talk about how they can relate on those illusions of certainty and the different things they do to try to get answers.
Mm-hmm.
Well, and also I want to add, for someone who's newer to treatment, it's really obviously difficult at first to do exposure therapy. So it's like you open this door. I've had this happen with people. You open this door where, okay, they know it doesn't work for them to, for example, health anxiety, to start Googling or looking things up online. But then they're just sitting there dealing with the discomfort in a sense, because they're not on the other side of the treatment where they see the benefits of that yet. So it's really encouraging for them to hear from people who have gone through treatment. So for example, like those panels at the conference, because then that motivates them to know, okay, this feels kind of, in a sense, not very hopeful right now, because now I'm just uncomfortable. So I haven't gotten to that other side of treatment yet to see the benefits, but I see these other people have, and that motivates me to stick with it.
Yeah, and you get to categorize the thing that you're struggling with at this conference. You see other people who didn't get diagnoses until adulthood, or they're just starting therapy, or they've been doing therapy and had some success with it. And it helps you put in perspective where you are with that journey. And, I don't know, gives you some more context for what you're dealing with.
For sure.
All right, before we wrap up, I know there are people out there who are feeling alone with their intrusive thoughts. I'm wondering if there's any words of wisdom that you want to give them, or any other final takeaway messages that you want to leave our listeners with.
I really would want them to know that there are so many people out there who struggle in the same way and basically struggle with these thoughts and intrusive thoughts and with OCD, for example, and that there's so many resources out there, whether that's an abundance of them are through the International OCD Foundation, but whether that's attending conferences or you can attend the conference virtually now, which is obviously much more accessible to a lot of people. There's online OCD conferences that are just solely online. There's live streams. I mean, they have live streams every week on their website, on Facebook, that you can watch them later. It doesn't have to be live. There's an abundance of podcasts out there, so that by listening to these things, you can really get a lot of support. And there's actual support groups too, and virtual support groups for people and families, so that they also don't feel alone in terms of dealing with OCD, and how there's just a lot of, I should say, support embedded with hearing these stories. Mm-hmm. And also the treatment success stories as well.
Where can people learn more about your work?
The main place where they can learn more about my work would be at my website, which I can't actually remember, New Orleans Anxiety and OCD.com. I should know that, right? The one thing I didn't remember, right? I was correct. Okay. The main place where people can learn more about me is on my website at New Orleans Anxiety and OCD.com. I don't have social media set up at the moment, something I've been thinking of, but I would say on my website would be the main place. They can always contact me there. They can read a bio, more information about me there. They can contact me through the website. They can email me, neworleansocd@gmail.com, and I'll generally respond pretty quickly, and any questions that they have to learn more about me that way as well.
Amazing. Well, I want to thank you so much for this conversation. You've given so much valuable information to our listeners. You're doing wonderful work in this space. I know that you have helped so many people already, and I wish you lots of success as you continue working with people who have anxiety and OCD, and I look forward to being in touch.
Thank you, and thanks so much again for having me.
It was a pleasure.
You too.
Thanks for listening to Curious Incident, a podcast for special needs families. Don't forget to subscribe for a new episode every month. For more resources and helpful information, check out our blog at dayanlawfirm.com. This podcast provides general information which is not intended to and does not constitute legal advice. You should not rely on this information for any purpose. For legal counsel, you should consult with an attorney to discuss your specific circumstances. Your listening to this podcast does not create an attorney-client relationship between you and the law offices of Adam Dayan, PLLC. No attorney-client relationship is established unless a retainer agreement has been executed between the client and the law offices of Adam Dayan. This podcast may constitute attorney advertising. Prior results do not guarantee a similar outcome. Any guests featured or resources mentioned on this podcast are for information purposes and are not endorsed by the law offices of Adam Dayan, PLLC.